You're listening to Medscape's In Discussion series on secondary hypertension, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Marwah Abdalla. Dr. Abdalla is a cardiologist, cardiac intensivist, educator, and scientist with expertise in hypertension, sleep, and cardiovascular health. She is the Florence Irving Associate Professor of Medicine at Columbia University Medical Center, where she serves as Director of Education for the Cardiac Intensive Care Unit and co-director of the Columbia Hypertension Center. She served on the writing committee for the 2025 American Heart Association, American College of Cardiology, Multi-Society High Blood Pressure Guideline. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Marwah Abdalla. Welcome to the Medscape In Discussion podcast series on secondary hypertension. Today's episode focuses on Cushing Syndrome, an often overlooked cause of secondary hypertension. We'll discuss why this condition is frequently missed, how clinicians can screen for cortisol excess in patients with hypertension, and what to consider when managing blood pressure in those found to have hypercortisolism. And with the 2025 American Heart Association, American College of Cardiology Multi-Society High Blood Pressure Guideline emphasizing routine screening for secondary causes, especially in resistant or early onset hypertension, this topic is more relevant than ever. First, let me introduce my guest, Dr. Louis Blevins. Dr. Blevins is a neuroendocrinologist specializing in evaluating and managing pituitary and hypothalamic disorders and various adrenal conditions as well. As medical director of the California Center for Pituitary Disorders at UCSF Medical Center, he guides a team providing comprehensive, state-of-the-art care. He has a special interest in Cushing Syndrome, also known as hypercortisolism, and has edited a book on the subject and written a book on the topic directed towards patients and physicians. Welcome to the Medscape In Discussion Secondary Hypertension podcast.
Well, thank you. It's my pleasure to be able to join you today.
So to start us off, why do you think hypercortisolism is still such an under-recognized cause of secondary hypertension?
That's a good question. I would have to say that I think it's under-recognized because it's a rare disease. And first off, people don't think about rare diseases as often as they do the common things that come into the clinical practice. Physicians are busy. They're seeing a lot of patients. There are time crunches and things like that. So you tend to want to treat the numbers, so to speak, and to get the blood pressure under control to prevent morbidity and mortality as a result of the hypertension. And sometimes you forget that there's a cause behind the scene that needs to be addressed. Another potential reason is the fact that no two patients with Cushing's syndrome are alike. We all learned about Cushing syndrome in medical school and residency in patients who look like Harvey Cushing's patient Minnie G, but it turns out most patients don't look that way. So it's not like you can say there's a zebra, it has black and white stripes. These patients have the zebra diagnosis, which is rare, but they don't look like zebras at all most of the time. Probably only about 20 to 30% of people do. The remainders are less than that, or they have a different constellation of symptoms and signs than the typical textbook case. So they don't scream, "Here I am, a zebra in your waiting room," as many other diseases would, or as we might expect Cushing's too. But people have in their mind that's what the Cushing's patient looks like, so they miss it.
Are there certain patient populations where you think it's especially easy to overlook?
I think patients with adrenal hypercortisolism are probably easy to overlook because they are the ones that most often don't look Cushingoid. Now, with severe disease, they will look Cushingoid with marked high cortisol levels, big tumors, for example. But by and large, most people with adrenal adenomas that have mild autonomous cortisol secretion or very mild hypercortisolism, they don't look Cushingoid at all. We recognize this is probably an emerging cause of, well, not an emerging cause, it's been there all along, but it's an increasingly recognized cause of hypercortisolism. And that it used to be thought that about probably 65% of people had pituitary tumor, 10% had a tumor elsewhere, and the remainders were adrenal disease. It may actually be 50-50. So half the people with hypercortisolism that need attention may have adrenal disease. The other half have either ectopic ACTH production or a pituitary tumor.
How much of this under recognition do you think is actually related to terminology? There are many terms and different, as you say, phenotypes and expressions. So, mild autonomous cortisol secretion, hidden hypercortisolism, Cushing's. How do you think these labels may contribute to confusion amongst clinicians? And can you clarify what these are?
I think they certainly contribute to confusion because people haven't heard them before. But I think that we're on the right track to sort of advertise and broadcast that there are more subtle occurrences of this disease process that we think of as a hypercortisolism, whether it's pituitary disease or adrenal disease, both can present with hidden hypercortisolism. And what's meant by that is someone has something like hypertension, osteoporosis, or uncontrolled diabetes. And then when they're worked up, they're found to have Cushing's. So they didn't look Cushingoid, so it was hidden, so to speak. It's kind of a misnomer because it wasn't hidden at all, because the hypertension or whatever the gateway diagnosis was there. That's the workup. So I don't really like the term hidden. I think it sends the message that, well, if something's hidden, maybe we better try to uncover it. So I accept it for that reason.
Yeah.
Mild autonomous cortisol secretion is a good term. I like to think that those people wouldn't have symptoms and signs unless they had relative hypercortisolism. That group of people have a normal urine cortisol level. So that's why it's called autonomous cortisol secretion, because you can detect that with certain dynamic diagnostic tests. But the truth of the matter is they wouldn't have hypertension or diabetes if they weren't producing more cortisol for their body. And everybody has their own normal cortisol production rate, and probably sits, if you check cortisol levels 100 times on me or you or anybody listening, we would probably see a normal distribution, a mean and a standard deviation. And that would be where our body wants to be physiologically. So if my normal level is 20 plus or minus 2 standard deviations, maybe it goes down to 7 to 27 or something like that, and I'm sitting at 40, which is still in a normal range, I'm making double the cortisol that my body needs. And that can cause hypertension, diabetes, insomnia, weight gain, and things like that. And that's the big trap, I think, out there, is that someone thinks of Cushing's, they do a urine cortisol, it's normal, and they dismiss the diagnosis because the cortisol level is normal, but that patient may actually be producing double or even triple the cortisol they should be producing for their body, and they're getting those clinical manifestations as a result of that. I like the mild autonomous cortisol secretion thing, but those people probably have relative hypercortisolism. I like the term pathologic cortisol secretion, and that's a term that I coined and published recently, that it's due to a pathology process. Is cortisol secretion, it defines it as abnormal cortisol secretion. Whether the patient's frankly hypercortisolemic or normal cortisolemic, I think that term is a good one. I like to use the term Cushing syndrome for people who look like that patient that Harvey Cushing described. Everything else I like to refer to as hypercortisolism. And if it's due to pituitary, I'll say ACTH-dependent pituitary hypercortisolism. If it's due to adrenals, we'll talk about ACTH-independent adrenal hypercortisolism, for example. I think that the terminology is evolving, and hopefully will evolve to a rate that we can keep up with it and educate people about it so that everybody's on the same page.
So, for clinicians managing hypertension in busy practices, what early or less obvious clinical features should prompt us to consider cortisol excess as a driver of high blood pressure?
So I'll answer that question talking about my own clinical practice. So I see a lot of people with Cushing's. Most of them have run-of-the-mill hypertension. They're on 1 or 2 drugs. Many of them are controlled, so that you can't really say, oh, it's just the people with uncontrolled hypertension or multi-drug resistant hypertension or those with hypokalemia, for example, and edema. You need to recognize that anybody with hypertension can have Cushing syndrome or hypercortisolism. And in that case, you want to look for other clues like abnormal weight gain, insomnia, things of that nature, some of the more mundane things that you can see in hypercortisolism in a patient that doesn't look like they've been taking high doses of prednisone, for example. Typically, if you had to pick out a group of people to screen and wanted to sort of catch those that were the most treatment resistant, requiring multiple drugs, who had hypokalemia, had a low renin and a low aldosterone because it's a syndrome of apparent mineralocorticoid excess, those would be the ones to think that they might truly have Cushing's. In fact, if you had to do a blood test to screen, probably looking at the renin and aldosterone and interpreting that in conjunction with the drugs the patient's taking, right? Because a lot of these drugs do affect renin and aldosterone levels. But most of the drugs for hypertension raise renin. If you've got a low renin and a low aldosterone and a resistant hypertensive patient, you probably have hypercortisolism. Pretty good screening test. But the dexamethasone suppression test, the 1 milligram overnight test, is a good screening test as well. But I think for someone who focuses on cardiology and hypertension, just check that renin and aldo. And if they're surprisingly both low, then think about hypercortisolism in that setting. There are other reasons they could be low, but that's a nice screen for that resistant patient in a hypertension clinic, for example.
So to follow up then, after you see that, what then should be the next steps for a general clinician?
So I, look at the history. Is there insomnia? Is there weight gain? Are there premature osteoporosis, stretch marks, easy bruising? Just look at the whole clinical picture, because that's going to get back to the Bayesian theories of the pretest probabilities being abnormal. Take a person off the street with no pretest likelihood because they don't have any of those things. The abnormal test results more likely to be incorrect. So I like to think of Bayesian statistics in the evaluation here, and you want to try to look at all those predictors to see whether or not your abnormal test is likely to be true or not. But then go with screening tests. And the screening test can be any number of things: a late night salivary cortisol, an overnight 1 milligram dexamethasone suppression test, or a 24-hour urine. Since many people have normal 24-hour urines, that's not always going to pick up the disease. The overnight 1 milligram dexamethasone suppression test probably has a false positive rate of 25 to 35%, depending on the dexamethasone level you require for a normal test and the cutoff you use. The late night salivary cortisol is not always great, because some people have normal levels, but they're still producing cortisol throughout the day instead of in a diurnal variation. That's particularly true of adrenal disease. You're more likely to see an abnormal salivary cortisol in a Cushing's patient with pituitary tumor than you are with early adrenal disease. So none of these screening tests is perfect, but I think they're all very useful in the context where you have high pretest likelihood of having disease. So, and I think any one of them can work, whatever works for the busy clinician. And then once you have a positive screening test, you have to go to a diagnostic test. And interestingly, our diagnostic tests are still the same screening tests. Some people will do a 2-day dexamethasone suppression test. Other people like to see 2 or 3 urine cortisols and things of that nature before they go on to doing imaging studies to try to find the site of disease. Obviously, an ACTH level helps you figure out if this is ACTH dependent due to pituitary ectopic disease, or low, in which case it would likely be due to adrenal disease.
Mhm. What about blood pressure monitoring? So, the guidelines are suggesting we should do more out of office blood pressure monitoring, whether it's home blood pressure monitoring, ABPM, ambulatory blood pressure monitoring. So, do patterns like nocturnal hypertension or non dipping also
Yes.
potentially raise the flag that there may be cortisol related hypertension?
I have not used those monitoring devices in my patients, but I'm aware of the literature that indeed you do lose your variation in blood pressure when you have hypercortisolism, because you're making cortisol throughout the day. And there's a loss of that variation, and nocturnal hypertension seems to be a real problem.
So I want to shift to a very common real world scenario with a lot of more imaging. There's a lot of more incidentalomas. So the adrenal incidentaloma, they're showing up more often. There's a great 2024 paper in Nature Reviews Endocrinology noting that about 20 to 50% of these patients have some mild autonomous cortisol secretion, and hypertension is usually the leading clinical consequence. How should clinicians think about these incidental adrenal nodules in the context of evaluating secondary hypertension?
That's a very good question. Obviously, these are common. Radiologists see them and report them, and studies have shown that most people don't get an evaluation. Other studies have shown that anywhere from 20 to even 45% of patients will have mild autonomous cortisol secretion. And when we look at those people in long-term studies, we see that they acquire additional morbidity and even some mortality over time, with an increase in hypertension, type 2 diabetes mellitus, progression of osteoporosis, neuropsychiatric symptoms and signs as well. So it's believed that they need to be treated. Chiodini and others in Italy recently presented at the Endocrine Society a paper showing that these patients actually benefit from adrenalectomy or some other treatment. They didn't study that, but you could treat medically as well, and you would see benefit and improvement in these cardiometabolic parameters of disease. that are related to these adrenal incidental in people with MACS. So I think it's critical to evaluate all of these patients, especially when they have a background of obesity, hypertension, diabetes, hyperlipidemia, or osteoporosis and maybe you use those gateway diagnoses as the reason to evaluate a person with adrenal incidentalloma. If someone had an abdominal injury and has an adrenal incidentalloma, but is normal weight and no other disease processes, you'd probably get away not evaluating that person. But as an endocrinologist, I feel the buck stops with me and my colleague. We should evaluate everybody. And I encourage primary physicians, if they don't know or want to evaluate, to at least refer to an endocrinologist to get an opinion. And everybody should be tested for hypercortisolism and hyperaldosteronism, even if they don't have hypokalemia and hypertension that's uncontrolled, in my opinion. And certainly if it's an adrenal medullary tumor for pheochromocytoma.
It'd be great to have, unified diagnostic criteria as well. I think one of the things that's for the lung nodules that really helped is the Fleischner's criteria, or people sort of, pushing folks to evaluate at a certain screening level. It's very, very interesting. So another challenge I think clinicians often have is distinguishing true Cushing's from pseudo Cushing states caused by conditions like depression, pregnancy, alcohol use, uncontrolled diabetes. So how do you think clinicians should approach these cases diagnostically when hypertension is part of the picture?
So that is probably the one arena of pituitary and adrenal medicine that is most difficult. I have seen patients referred to me by other endocrinologists where they said the patient had pseudo-Cushing's and they ended up having an adrenal tumor that we removed and they recovered. Same thing with pituitary disease. I have seen people that I labeled as having pseudo-Cushing's who 3 years later developed a pituitary tumor and had pituitary disease all along. My overreaching conclusion is that anytime you say that you think a patient has pseudo-Cushing's, you should send the patient for another qualified opinion by an experienced clinician. Because the more eyes you have looking at a patient and reviewing the data, the more likely you'll arrive at a correct diagnosis.
So a lot of times, patients go through many, many different testing. You see many subspecialists, like you just said. What can we do better as clinicians to sort of prepare our patients for the workup and the journey they may go through while undergoing testing, seeing subspecialists, and for some undergoing surgery?
This is a difficult journey for patients because they come to you and they've been sick for years or have had the comorbidities for a long time, and they're frustrated because those can't be controlled. And they hear they may have a particular diagnosis and they want to know yesterday whether they have that, and they want to move to treatment right away because it's like now there's hope, right? That they can get controlled and maybe come off a whole group of medications. I think it's important as a clinician to tell patients that we need to take our time and proceed in a logical, stepwise fashion to evaluate them. First, confirming that they have the disease, and then second, trying to establish the differential diagnosis and work through that before we can even arrive at a treatment plan. I mean, the NIH reported in the 1990s people that it took 20 years to find the culprit, to find the tumor that was an ectopic ACTH producing tumor. I've seen people present to me who've been evaluated off and on for 15 years. And, it was obvious to me they had Cushing's all along, but the clinicians evaluating them weren't entirely sure. And that's not anything against the clinician because experience matters in this arena. And it's important to get people to physicians who have experience so that they can, if you will, accelerate that workup. But patients need to learn that not all tests are going to be informative. And sometimes a tincture of time is what we need, 6 months to repeat test 6 months later, maybe a year later, just to see, because Cushing's usually progresses in most people, not always the adrenal adenomas, but with pituitary disease, it will. And I think it's important to prepare patients for the fact that this might be a bit of a journey to get to diagnosis and treatment.
It sounds like an important step is really having a great clinician-patient, relationship, especially if they're going to go back and forth through things in order to get them through this journey. So why don't we wrap up now by talking about management pathways? Is there a need to modify antihypertensive medication strategies while evaluating or treating hypercortisolism?
Patients with hypercortisolism tend to respond best to drugs that block the aldosterone receptor. If patients haven't been on those drugs, it's good to think about them. Whether you use spironolactone or pleuronone, those are good drugs. Some of the ARBs work as well, but not as well. Certainly alpha blockade's not going to work that well, and calcium channel blockade doesn't work well either, nor beta blockade. So I think once you sort of figure out that you're on the pathway to Cushing's, it's important to try to choose some of those drugs. Still, they're not going to work, or not going to work well, I should say. Treatment really comes down to identifying the disease state and treating that disease state, whether it be with medication to block adrenal corticosteroid production, or adrenalectomy, or removal of pituitary tumor, or say a carcinoid in the lung causing ectopic ACTH. It really comes down to treating that underlying diagnosis. And once you treat the patient, you usually see, not in everybody, but you usually see hypertension resolve. Some people do require medication still. Probably they had endogenous hypertension that was just worsened by having a disease state that exacerbated it. And on that line, I think the people that look like Harvey Cushing's patients are the ones that probably have the multigenic condition that leads to what we call metabolic syndrome. So if you have metabolic syndrome in your family, and you're going to have that anyways, if you get Cushing's, that's when you probably most likely look like Harvey Cushing's patient. And I just sense that, but based on 35 years of doing this and seeing a large number of patients and figuring out, why do some people look like they have Cushing's and other people don't? When their families start coming in, you can see, well, these people have metabolic syndrome. There's diabetes, hypertension, and obesity. And the Cushingoid patient who has that's going to look more Cushingoid. And it may be that the person who gets the multi-drug resistant hypertension is the one that has endogenous hypertension anyways, and then it's just compounded by the Cushing's. And the people that I see that have what looks like run-of-the-mill hypertension are the ones that just have it from hypercortisolism. We always think about these patients having the hypertension, hypokalemia, and multi-drug resistant hypertension, but that's actually rare. I've seen 4 people this year, but maybe usually one of the 40 or so people I see every year would have that pattern, but it's been 4 this past year. Kind of interesting that they all came at the same time. It's usually maybe 50 people I see with Cushing's a year, and 1 or 2 might have hypokalemia, but this year it's been 4 of them, so it's very interesting. So I think finding the disease state gets you onto the pathway of treatment. And then usually if you are going to come off medications, it's a period of 3 to 4 weeks. People resolve their medication.
That's fantastic. So we've covered a lot today, Dr. Blevins. Thank you so much for joining us. If you had to leave clinicians with your 3 key takeaways about why hypercortisolism is missed, when to screen, and how to manage blood pressure, what would they be?
I used the term zebras before. That's the term we use in medical school. The patients with hypercortisolism are zebras. They're rare, but they often look like horses. So think about Cushing's in anybody with hypertension, and especially if they're on more than one drug to try to get control. It doesn't take a lot of energy to think about it and decide whether you're going to do a test or to think about whether they have some of the other symptoms and signs. And when you think about all the other things we do, it's less energy to do some diagnostic tests than it is to arrange for some other things that we do for our patients. So think about it, screen for it when you think about it, and that's how you're going to find patients. And once you find a case or see something else that might be related to Cushing's, like that adrenal adenoma that's detected instantly on a scan, refer a patient to an endocrinologist for a bona fide workup, and let them do all the thinking for you and share in the care of your patient.
Great. Well, thank you so much. And thank you all for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on secondary hypertension. This is Dr. Marwah Abdalla for the Medscape In Discussion podcast.
Thanks for listening to Medscape's In Discussion Secondary Hypertension podcast series with our host, Dr. Marwah Abdalla. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on secondary hypertension.